I'm Nazima. I'm based at Addenbrooke's and the University of Cambridge. Like Andy, I'm a PICU, I'm a consultant in paediatric intensive care and an academic in the university. And we've been interested in this area for a couple of years, and I wanted to present some of the problem and how challenging it is, because it's a big part of the clinical burden in the population we treat. As with adult intensive care, what we're dealing with is a low threshold to use antibiotics, because we're dealing with very acutely ill children in which we don't want to take a risk of not using antimicrobials. And amongst the about 24 to 26,000 annual admissions to PICU in the UK, around 6,000 of those come in with a primary respiratory diagnosis. So if a quarter of our patients, and most of those are infectious, are potentially community-acquired pneumonias, then this is a big burden. On top of that, the issue of ventilator-associated pneumonia in the sickest of children isn't well documented or defined, and the diagnostic yield of how we manage these in a timely manner to rationalise antimicrobials safely and convince clinicians to sort of target appropriately is what is under discussion. So this is some of the work we did in our unit. The first thing we looked at, just retrospectively, is in terms of what was the current situation in terms of how long our children are on antibiotics. And what you can see here is that in children with a lower respiratory tract infection, the positive culture yield was very low, and that around 1/5 overall of children with either nominally an acute or after prolonged admission cultures taken have a positive result that could help us to rationalise antibiotics. And of course, the time taken is multiple days. And what we found was that in this cohort of children, they were on antimicrobial therapy, systemic antimicrobial therapy, for a median of 2/3 of their PICU stay. The median time of PICU stay in most children is about 2 days for ventilated children, but for those who subsequently get VAP, it goes up to 5 to 7 days. So it's not a huge amount, but the number of children getting antibiotics is pretty large. We've been running a study, both a lot, and John Clark, who's here, my PhD student, along with Andy and Vilas, who are adult intensive care students, called Rascals, a small single-centre study, to see if we can implement and look at the challenges of how we diagnose and implement a rapid diagnostic approach to treating a pneumonia in our patients. So I'm looking at community and ventilator-associated lower respiratory tract infection in children admitted to our unit, requiring mechanical ventilation, and to see how, and this was started about 2 years ago, just prior to or around the time of the pandemic starting, looking at multiplex PCR using a local Tachman array card that Andy and Vilas had developed with our microbiologists, and seeing if we can take this and compare it to standard microbiology and virology in terms of concordance. Alongside doing routine culture, we undertook 16S RNA sequencing. Because this is not a ward-based array, it had to be done in the microbiology departments. It's something that we were dependent on microbiology staff, so it was just a Monday to Friday test. Was it timely enough to make any difference? Was it feasible given the sampling issues in children? And what were the staff perspectives, just to look at how we ran this. These are the pathogens that we were looking at on our Tachman array card, and looking at cycle threshold. We changed it at one point when the pandemic started to include SARS-CoV-2 within, to be able to run one array to get all of our target pathogens. It's a mix of atypicals, fungal, viral, and community and potential ventilator-associated targets. The problem for diagnosing infection in children is the sampling. In these ventilated children, we don't, because their endotracheal tubes are quite small, we don't tend to do a bronchoscopy-directed lavage. So this would require a deep suction. So we did a blind bronchoalveolar lavage, taking a small volume up to 10 mils, but based on patient body weight. And this is more aggressive than the standard ET suction, but we felt it would be more aligned with a sort of more rigorous bowel than what we'd normally do. We concurrently ran microbiology and virology. Our focus, and what I was going to talk about here, was obviously the bacteriology, because that's of interest in terms of the issue of prescribing. The clinical team were provided the results through the microbiology service, and in this study we did not direct their management as such. This was just a feasibility to see how it was implemented. After we looked at all admissions over the period of the study, and 100 children were enrolled in terms of, this is a mix of community and ventilator-associated pneumonia, children who were ventilated, who had suspected lower respiratory tract, who we were able to enroll within the timeline of the study as early as possible following a suspected diagnosis. As with our general population, many of them were small. The median age was 1.2 years, which is why sampling is challenging. And a lot of our children have got a comorbidity which may influence how we even treat community-acquired pneumonia. They may have tracheostomies, they may have other issues, neurological issues, aspirations, which mean that atypical or antibiotic resistance bacteria are going to be a problem even in the community-acquired population. PIM score is just a disease initial sort of how sick are they and risk of dying score, and their requirement for ventilation overall, this is in the whole group, was 8.4 days, and on PICU 10.5 days, with a good survival of 94%. And the vast majority, obviously, CAP. We had 17% VAP in these children. As you can see here, this is our patients, although the majority of them are respiratory because this is a pneumonia study. These are likely the VAP patients that would subsequently, because they were so sick, we looked at them for infections, and this is the patients, a breakdown of the respiratory patients, again, largely infectious, or bronchiolitis, pneumonia are the bulk of our admissions, particularly in the winter. Asthma and infectious exacerbations of asthma are other issues. We do get some severe or major airway surgery and other issues as well, but most of it is either bacterial or severe viral infection. In terms of looking at these patient cohorts, we found that that the VAP patients were a little bit older and a little bit sicker, and had obviously a broader range of diagnostics. Despite this being a lab-based system and only Monday to Friday, we did find that the clinicians appreciated an earlier result time. In median times for getting a positive or negative culture, getting a definitive culture result was 72 hours compared to the 25 hours for the Tachman array card. The problem, of course, being patients coming in on Friday or the Friday night or the weekend. And this meant that it certainly gave us a faster result, and clinicians in sort of surveys felt that was a real benefit. As with the previous slide that was shown regarding what are we growing, rhinovirus, highly common, as well as then a real mix of things. Quite often, particularly with the VAP patients, we had multiple hits of enteric organisms. Patients, we did have a cycle threshold. We used a cycle threshold of 32 to try and give a cut-off of whether this was likely infection or contamination. We had obviously a much better rate of detection. How did that compare with standard microbiology culture? If we only look at the bacterial targets, you can see that very little was grown, but we got organisms, and generally we felt, that this where we we're not sure about the CT threshold. The clinician had a degree of perception, bedside judgment, and so, but the common bacteria included Haemophilus, Moraxella cotralis, Strep pneumoniae, Staph aureus, common pathogens that we do expect, but a much higher yield. For sensitivity, we only compared those, so numbers are quite small because we only had around 20 that had positive cultures. 3 of them had positive cultures that didn't have a positive TACMAN array, so the sensitivity was 89.5, specificity of 98.4, but this is comparing to routine microbiology. When we look at including the 16S sequencing, we certainly, where cultures were negative, we then looked at their 16S arrays, and certainly they matched for almost all of our TAC arrays, so it works. The CT value corresponds, so in terms of having, where we had negative culture, those patients did have obviously lower prevalence, and a CT value of 28 or higher was where patients didn't show bacterial growth. We did survey our clinicians and the nurses, asking them why they sent them, and it wasn't always, interestingly, because of suspected infection. Sometimes, and especially in the early stages of the study, where they would send them off for whatever as part of a septic screen, just as part of their admission screening, because they didn't know what else to do, because they were worried, and that therefore they would just take it to check. So these things need thinking about how we manage the use of such an expensive resource in any future work. Because clearly that's not always ideal, because it gives results that are then acted on. This was something that this just shows, again, how our clinicians approached it. So where we had a cycle threshold of 30 or less, we advised that they could consider that as a likely positive, a true positive infection, and then they could adjust their antibiotic therapy as appropriate in conjunction with microbiology, who were on board, obviously, with this investigation. Then for some, for the sort of 30 to 35, we advised clinician judgment. And it was quite interesting. We had a patient with Coxiella who had a cycle threshold positive hit of 32. She was a child who initially came in as query COVID. It was early in the pandemic. Cultures were negative. Everything was negative. And we thought this was ridiculous. But in fact, she did have a parrot that had just died. And we treated her appropriately, and she improved. And that's something we wouldn't have probably picked up for quite some time if we hadn't had this array. So it was a useful array. Our clinicians liked it, but our small study didn't look at how we then managed the result. John then did interviews with our consultants with every single test in terms of what did they do afterwards. And whilst some continued their antibiotic therapy, others did report that they either stopped them or de-escalated or escalated as appropriate. Some of the feedback was that initially, particularly as we required a specific broncho or lavage, which potentially puts the patient at risk of hypoxia, so requires bagging and some degree of higher competence than just taking a suction. That is a problem in busy units, especially through the pandemic, working in a cubicle. But once they were used to it, and used to taking that volume, they became more comfortable with it. We didn't see a specific increase or decrease, though, overall in days of antibiotic therapy. This is our Rascals cohort, and we then this is just the community-acquired pneumonia patients, and this is a previous cohort of community-acquired patients, and you can see that no real difference in terms of days of antibiotic therapy and no difference in terms of days of ventilation, but these were not primary outcomes. Our main thing for this study, for this internal array, was to look at how it implemented, how the methodology should be, and whether or not it was feasible and practical to get results in a timely manner. We looked at antimicrobial severity index, and again, no real overall difference in terms of the score, as best as a score as we could find, to try and break down the classes used. Some reduction in aminoglycoside use, but really no overall difference in how antibiotics were prescribed. There's still some work to be done there to say, did we look at days, how prescription changed in the days post-test and post-result. We also did a small survey. At the moment, we've just got from ESPNIC and the Australian, New Zealand AMSICS, as well as the UK PICU. So this was a survey, again, self-selected survey, and we asked clinicians to tell us how many patients at the time they were doing the survey were ventilated. The reason the numbers are digital is because some units had more than one clinician respond, and therefore we took the mean value. So, but overall, the suspected VAP at the time they did it was around 12%, and the suspected community-acquired of 16% of ventilated children. And this fits with ours, which was that the 2/3 were on systemic antimicrobial therapy of all the ventilated patients at the time. So antibiotic therapy is a big problem. And the use of molecular diagnostics is not particularly high. I know I'm looking forward to hearing more about Inhale. I know you've done some work in the PICU community alongside the adult. But I think something better is needed and something fast, because the issue is that we're treating these very sick children, and we would like to rationalise, but in a safe manner. There's very little done in the PICU community. This was a Chinese study looking at, again, a case control study, looking at respiratory pathogens using a film array. And again, here what was interesting was they had a higher number of patients, 300. They did show a significant reduction in using the film array in antibiotic therapy, and also in terms of the cost of hospitalization, because they were apparently able to sort of de-escalate and manage their patients' antimicrobial therapy more effectively. But there really hasn't been very much done. Oh, sorry. In the PICU. So there is a lot of discussion in the PICU community about looking at rapid diagnostics, both from the pathogen as well as the host response, to look at both diagnosis, predictive risks, particularly for ventilator-associated pneumonia, prevention strategies, including plus or minus the use of SDD. These are all discussions that are going on, but certainly it was the second most highly rated topic in the recent PICS SG prioritization exercise. So the questions that people are asking are, will it influence practice? Is it safe, both the taking of the sample as well as the changing of antimicrobial therapy? And what are the outcomes? And I know I've been chatting to Vicky as well as to others in the PICU community about how are we going to say that this is effective. We need to understand the UK PICU burden, particularly of VAP, which is really not well defined, but certainly has a morbidity, an economic outcome that's important for us to consider. How do we help our clinicians to safely reduce antimicrobial therapy? How do we say this is an infection, but make it the safe decision about how to act on the result? And I think from what our study perspectives are, that I think we need to think about the bedside nebulous thing that you were talking about, Vanya, in terms of the clinical judgment, as well as obviously the how we class resolution of disease, a finer measure than just ventilator requirement. So that's our experience. Obviously, I've mentioned John, whose PhD the bulk of this work forms, as well as our research team, Andy and Vilas on the JVF ICU and the Action and Gates and Adam Brooks Trust. Thanks very much.
Well, thank you very much, Nazima. That was great. I get the feeling we're all sort of ending up kind of in the same place with these independent talks. The title of which I dare say might be, we've got some great technology. how do we make it work?
Yeah.
Questions for Nazima?
Yes.
Is this still working? Great. Yeah, thanks for an excellent talk. There's so much in there. I'm a big fan of the syndromic molecular approach, and I guess the TACMAN array card is a sort of nuclear version of that, isn't it? Where you've got, I don't know how many targets on there, was it 60 or 80 or?
It's 56, isn't it? 52.
52, yeah, as compared to however many targets the film rate has got, is sort of 30 or something, isn't it?
27 more.
37.
Yeah, and so I guess the sort of question/comment is about that and about your choice of target. So I guess you can understand why somebody would think a greater choice of targets is better, because I guess if it's truly comprehensive, you can be reassured that you're not going to miss these sort of golden eggs that Vanya was talking about, where you detect something that nobody suspected and you wouldn't normally routinely test for. But of course, there's a negative side to testing for so many targets as well.
Yes.
In that you're going to get a lot more co-detections, and you didn't show
Absolutely.
us that, but I'm guessing you got a ton of co-detections.
Very much so. Yeah.
And of course, you increase the risk of detecting things that are of highly questionable clinical significance. And I know that when BioFire were developing their technology, they had several targets initially on it that they subsequently dropped. Pneumocystis. Tell me if I'm speaking out of turn or breaching the terms of my CDA. But they dropped it because they were getting so many hits that were of questionable clinical significance, they decided that it wasn't worth doing it. So I guess, you have to cut your cloth. You have to be doing your targets to pick up the things that are most relevant in your target population.
Yeah.
I saw that you had things like Candida on there as well. So
Exactly.
it's just really a comment there about, do we really need to have such a highly multiplexed, do we think that this is a good thing? Because if you're detecting many more targets, which are not of clinical significance, the risk is that people are actually going to use more broad-spectrum antibiotics and not less.
I think that's a really good question. There's a lot to stay there, isn't there? And some of it I may draw on Andy and John as well. First of all, I agree. I didn't show it because there is so much to show, but that we did have multiple targets, particularly when we had a viral infection. But, some of it was believable because we'd have a viral and then a bacterial pathogen at the same time, because a lot of our kids get antibiotics when they've got an RSV positive bronchiolitis, because that's why it's a co-infection. So we believed it, that we used the CT value a lot to guide us, and we did also talk to the microbiologists. In terms of choice of targets, I know that was done with our microbiologist Martin Curran and obviously Andy Villas. We focused on ICU specific pathogens. We found it helpful. What was interesting, before I ask Andy to comment, what was interesting was particularly with the VAPs, the multiplicity of the Enterococcus species. And what we wanted to do was say, well, how much of that is normal for a supine patient at day 3 or day 4? And what I'd quite wanted to do, what John and I were hoping to do, is day 1, 2, 3, 4 bowel sampling of a non-infected patient or group of patients to make sure we can, because the VAP diagnosis still remains problematic, I think. I don't know if you want to talk about target choices, Andy.
So we started designing this card with having come at it from a sort of previous lot of culture-based work that we'd done. And we said, well, what organisms did we find on culture? And then we looked at what organisms we were particularly worried about in our patients. And my unit is just over the corridor from Nazima's, but has a high burden of immunocompromised patients. So we did a lot of solid organ transplants and hematology oncology patients and so forth. So we skewed the card towards some of those low pathogenicity organisms that most of the time, to be honest, we ignore, but we thought might be of interest. And then the other thing was we also wanted to make the card experience as culture-like as possible, because we thought that if you did that, clinicians would engage with it better. So we often get reports of Candida on our standard cultures, and we usually ignore it, almost always ignore it, unless we think this patient has got extensive candidal colonization and a high risk of candidemia. But that was the reasons for including those low pathogenicity organisms in there. And then I think the thing that certainly we learned on the adult side was that you have to interpret this in the clinical context of the patient. So if you blindly treat things, then you'll go wrong. We're very lucky. We have daily microbiology MDT, so they come and we discuss every patient. They were very much involved in the implementation of this, and we lean heavily on their advice when we're managing antibiotics in general, and found this was an adjunct tool. But I could see how that wouldn't work in other settings. So there are definitely risks. The only other thing to say is we had an earlier version of this card which had a much more restricted range of organisms on it, mostly community-acquired pneumonia focused. And we found it had almost zero impact on practice, because the reason for that was because it didn't cover the organisms that we were worried about. So it didn't have the E. coli, the Pseudomonas, a lot of the, mostly gram-negatives. And so people said, I'm not willing to change my, we had a couple of spectacular hits. We had a non-pneumophila legionella and so forth. And you go, great. And they said, well, I'm not getting rid of the gram-negative cover because I don't know this patient hasn't also got a gram-negative. And it was only, so that was another reason for expanding the coverage. So I think to some extent coverage is kind of king, but with a tarnished crown, and we have to be careful how we use it. Sorry, Nazima.
I did this, I often previously worked at and the thing that I found most useful about it when we published on this card was that it confirmed straight to me more than another patient from whom we hadn't known it, and so it did allow you an opportunity to nanotherapy, because in the patient that community acquired pneumonia, in whom you have definite evidence of straight pneumonia, then you can nanotherapy. So that I think was useful in that context as well. So confirm your diagnosis and then give people the confidence to not continue conventional antibiotics.
Yeah, I mean that works for strep pneumo, but it doesn't really work the same for most of the other targets.
Yeah.
So I think on that, what with us being paediatric focused on this, if you look at the demographics on those slides, half of our patients are pretty much bronchiolitis. And when you talk to clinicians and some of the qualitative work we've done, is they've said if we had a narrower panel and we were confident that we covered a whole number of bacterial hospital co-infections, they wouldn't be happy to stop antibiotics. So I think it's really important in our population that we are able to cover for those bugs if we want to impact on prescribing practice. The other thing is that probably about 10% of our PICU patients occupy about 90% of our bed days in PICU. Most of those children are technology dependent, have multiple comorbidities, and have a whole host of, sort of gram-negative colonisation, and have a lot of other atypical bugs, and they're our biggest users of antibiotics. So I think we also need to have good coverage for those. But as Andy said, we did have good microbiology input, and we did ask clinicians, did you have problems with the high sensitivity of the test? But they actually went back to us that they were quite comfortable getting that extra information, and we didn't actually have an increase in antimicrobial use with the test, interestingly, including the spectrum of therapy as well.
Thank you for that. I think Luke was next.
Okay, and there's a question at the back as well.
And then, ladies
Sorry,
first.
I'm Catherine Aldridge from Newcastle, and I'm a microbiologist as well. I thought that was a really interesting and comprehensive and excellent presentation, and there were several, I was sort of going through it thinking several things and almost changing opinion as you were going through. So the first thing that really struck, that sort of came out to me was when you had a graph of what you detected compared to the culture, and you had detected 8 times more bacterial targets than we would pick up in culture. So being a microbiologist, my thought was immediately, oh my God, what happened to their antimicrobial prescriptions on that unit? It must have gone up. I know that's not.
But you see, they were getting it anyway because the clinicians used their judgment. So it was interesting.
But then that was consolidated by the slide where you said, why did they do this test in the first place? And some of the reasons were like parental reasons.
Yeah, very vague. It's interesting, isn't it?
They're picking up even more bugs that are perhaps not necessary, and it's all coming into this whole sort of pre-diagnostic probabilities, etc.
Yeah.
And then of course you presented data to say that that didn't happen. You didn't. In fact, there were times when you got reductions in your in your good AMS essentially. So then I was sort of wondering what are the reasons for that, and really this is all which is what we've already been saying before. We've got highly complicated patients that were already on maximal antibiotic therapy anyway, so haven't got anywhere else to go up anyway. You've got your MDTs and you're sort of doing your clinical decision making. anyway. So then, as you say, I reached the same conclusions as you. It's like, where does this test? Yes, it gives us all this extra information, but is it actually adding to what we're doing already? If it's not actually impacting on what we're actually doing. But yes, it's really useful to know, especially the co-infection. And clearly, I think it is going to have potential to help with our antimicrobial stewardship.
I think, yeah, just as long as we work, with our microbiology departments. And I think what was interesting, I was chatting to someone at Birmingham who's implemented some kind of positive feedback pathway in terms of rationalising antibiotics and shown a sort of appropriate reduction in use by feedback from the microbiology team when they do a de-escalate as to you did this was good because that actually made a clinical impact. So I think there's so many questions. That's why it's really useful to chat to you all about it. Sorry, Vicky, you were going to say something.
I just had a question about the target selection again. So, am I right in thinking there was only one resistance target, which was MECA? What was the reason for not putting ESBLs or copper-penamases on there?
At the time, that was the one that we'd worked up and was on the previous card. I agree. I think there is huge value to measuring these, and we have a separate card.
Yeah, we've been doing an AMR gene card. I haven't shown you that data. We don't have much of a problem with AMR, to be honest, in our PICU. So each of these kids also got that, is going to have that run.
Yeah.
So, but again, this is just a work in progress, so that's why I think.
I know a big, I think probably with AMR, I think you have to get the balance right if you can't.
And what's significant, what's
if
real.
You can't target, if you cannot tie it to the organism, because I know with the curetas, which the original curetas cartridge had lots of antibiotic resistance genes and some lower value resistance genes like standard beta-lactamases, and it was a complete nightmare because you didn't know what went where, whereas I think if you do it like the pneumonia panel and you just only have carbapenemases and CTXM, then it's much more better to justify treating them.
No, we've done some environmental testing in Addenbrooke's in air and surface and so forth, and the AMR genes is terrifying, absolutely terrifying. But what's interesting is a lot of them are ones that we actually haven't seen clinically. So we've picked up NDM and so forth, and we haven't had a case of that for quite a long time. But yeah, it's absolutely, so there's a major disconnect there between what's in the environment and what's in our patients, and then what's infecting.
But can you be sure you didn't have a case of it? Because if it's not grown, if your culture's less sensitive and it's not grown, then no one's going to take it.
Is it wood? You just put everybody on Maripel and you'll grow enough of it.
That's the approach we take in my unit. Yeah, absolutely. It works very well.
I think this is great. More and more hands are going up. I think Luke and Dan wanted to ask a question or make a comment. If it's super quick, because
it was about, I was interested in the discussion about, you mentioned that some of the targets on this particular panel you choose to ignore frequently, and there are the pneumonia panel, the commercial decision has been made not to include certain pathogens on the panel. I'm interested in how people make this decision about when to ignore things and when not, because I think the discussion was going that if a pneumococcus was detected, you would always regard that as pathogenic. Whereas some things are very frequently ignored. And I'm thinking about our population, adult population, maybe with chronic airways disease like COPD or bronchiectasis, who are often colonized with Haemophilus or Pseudomonas. When do you decide what to ignore and what not to ignore? And how do you restrict the panel versus and how do you write it down? Because I'm assuming your decision, my decision as a clinician in a particular situation, might not be the sort of decision that my colleagues would make, and standardising that sort of decision making is really challenging. It is.
I mean, PCJ I think was an early one that caused some trouble in PICU because we routinely tested for PCJ in pretty much all of our patients because of the
it caused a lot of alarm for us. My colleagues
were. Oh my God, what's this? And as a result, I suppose it's about familiarity. It's like we fairly frequently see it in patients where there is no suspicion that they have PCJ pneumonia because they have an intact immune system, and we know that it's a colonizer, and it's found fairly frequently, and indeed that's the reasons why it's not on some of the commercial panels. So I suppose it's, you know, if you don't want to find something, then don't go looking for it. But would you take away, you know, like D-dimers, you know, you mentioned it earlier, you know, it's a cruddy test, isn't it? Really? Well, unless you use it properly, in which case it's an excellent test for risk stratification. It has its place. If you use it appropriately, think about your pre-test probabilities and so forth. So, yeah, I think, and the advantage that TAC has at the moment is that it's customizable. Now, there are all sorts of issues around conformity assessments and so forth, and you know, not having IVD approvals and things. But it does allow a degree of flexibility to say, well, actually, in our hospital, we've got a thing called Elizabeth King meningitis septica. It was in our pipes and was recurrently turning up in patients. I haven't seen it in any other hospital I worked in the UK, not been a problem. But because it's been a problem, now we stuck it on our card. And actually, we've changed all the pipe work and it's gone away, which is nice. But, you know, there's a degree of being able to adapt things to your surgery, or like in Darwin, where you know, myelinosis is a major problem. Well, that's not going to get picked up on any of the commercially produced cards because they're all focused on high-income countries in the temperate parts of the world. And we're going to have to find solutions for those areas that are, you know, have different pathogen spectrums.
On that note, I think, thank you very much for those comments. I think it's been a really